Hello, my name is Dr. Yvette Gozzo, and I'm a pulmonary critical care and sleep specialist. I'm going to be talking about the evaluation and treatment of cough today. For most people that I'm talking to right now, you've experienced cough at least once in a month because cough is a normal and natural occurrence. So what is a cough and why do we experience it? First, I want you to remember that cough, it's an explosive release of trapped and pressurized air. It's a sudden opening of the vocal cords, and it is one of the most common reasons people come to the doctor's office. In 1 year, consumers in the United States spent over $6.8 billion in the management of cough, and that has nothing to do, and this was prior to COVID-19. So cough has become much more of an industry today. So when you're looking at cough, it is split up into 3 phases. First, we have an inspiratory phase. Usually we take in about 3 liters of air. Then we have a compressive phase. And during that phase, we actually have contraction of all our chest muscles. We build up pressure in our chest and we close our airway. So it says glottal closure, but in layman's terms, we just close up our airway and we build up pressure. And then we have a sudden opening of those vocal cords in our airway and we release that pressure at a high speed. And it can be as fast as 50 to 500 miles per hour. And that's pretty extraordinary. I mean, it's the reason why people are doing what they're doing with the mask, because you can cough in one end of a store, and with a really strong cough, you can aerosolize and send secretions everywhere at a very high rate. Afterwards, we have a recovery breath. All of those phases have to be functional for a cough to be effective. So the question is a cough needed? And when I first started, the answer was yes, it's needed. We all naturally cough. Once in a blue moon, we all have a cough just to clear our airway, to clear secretions, and sometimes to recruit lung tissue that might be a little bit relaxed and sort of smushed down at the base of our lung. So it's a reflex that is generated from irritation or stimulation of our bronchial tissue. That means pretty much from our larynx, which is our throat, all the way down into our lungs, we can stimulate this cough. And it is very much a critical element for self-cleansing, and it protects our lungs. Anything that goes into our lungs has only one mode of coming out, and that's us coughing it out. And so it is extremely necessary. This slide really does tell you how much nerve input goes into a cough. It is not to be confusing, and it doesn't mean that you have to understand each one. The CN stands for cranial nerves, and we have a lot of different nerves that pick up and are that contribute to stimulating cough. In our nose and sinus, we have a cranial nerve number 5. In our throat, we have cranial nerve number 9. Around our heart, we have cranial nerve number 10. And the important part about this is that we have many locations and nerves that are sending input to our brain that can generate a cough. Our diaphragm, cranial nerve number 10, and the phrenic nerve. Our ear canals can get stimulus for cough. Our trachea, our actual tubes that lead to our lungs, the esophagus, our food tube, our stomach, and even the lining of our lungs. So this slide really just tells you that there's a tremendous amount of input from the start of our nose and our ears all the way down through our lungs down to our diaphragm, and even crossing the diaphragm into our stomach, that can cause and trigger a cough. As you see here, different things that may contribute: inhaling particles, so inhaling dust, wonderful Santa Ana winds come by, any mucus present anywhere from the start of our airway to below the diaphragm. Inflammatory secretions, so not just infection, but allergy can contribute to the cough. Abnormal tissue growth anywhere where we have nerve endings that may trigger or stimulate the cough reflex. Foreign bodies in our airway, yet again from our nose, ears, or down through our airway. Pressure in the bronchus, so if something is leaning or pushing on the bronchus, it can trigger a cough. As well as medications, and the most common medication that exists is the ACE inhibitors, and we have a large population around the world who are on ACE inhibitors for blood pressure. It's important to realize that sputum, it doesn't tell us as much as most people think. Very commonly we hear my sputum has changed from yellow to green or it's gotten thicker, but sputum with cough, it doesn't really tell you the cause. It can be a lot of different things. Chronic cough, you can have chronic bronchitis, bronchiectasis, which I'll explain in a little bit. A lot of bronchiureas, things that cause the bronchi or the lung tissue or even the back of the airway to be inflamed. Acute causes, pneumonia or bronchitis, or even sinus problems. So a lot of secretion can come from up the upper airway as well as the lower airway. It's important to take notice to the triggers of cough. Cold weather, talking or laughing, sometimes being exposed to something in particular, person who's wearing perfume, an animal, or even a particular season where we cough more. Noticing when the time occurs also helps us figure out what causes and can contribute to the cough being developing. Cough that occurs post-meal or associated with, a cough that occurs post-meal like reflux or aspiration. Nighttime occurrences, things that can trigger a cough that occurs more at night, including asthma, reflux, or postnasal drip. And things that may disrupt sleep, coughs that may wake you up, can be associated with reflux or postnasal drip. So it's important. The timing can tell the doctor or even the patient when or what may be contributing to the development of that cough. So when you talk about cough therapy, first and foremost, as mentioned before, we have to figure out what caused it and treat the underlying cause. That's our first goal, as opposed to masking it. When we do that, history is absolutely necessary, knowing our patients. So most people will go in and see their primary care physician, and their primary care doctor will already know pre-existing disorders, as mentioned there. If you've had chronic postnasal drip, asthma, reflux, bronchitis, bronchiectasis, which is scarring of the actual tubes of the lung, if you have a history of smoking, if you have a history of work exposure, working in different factories, construction, demolition, things like that, chemical exposures in the past, whether you're on ACE inhibitors or not. So all of these become very important to discern acute cough, subacute cough, which is cough that's been there for a little while, and chronic cough, cough that's been there for a long time. And then we evaluate you with a workup for cough. And we look at the physical exam. From the moment you walk into the room, we like to look and see what's going on with this patient. Is the patient short of breath? Are they struggling to breathe while they transfer from the chair to the examination table? When I look at the face, do they have puffiness around the eyes? Do they have dark patchy colors underneath the eyes suggesting sinus congestion? When I look into the airway, swollen turbinates, which is swollen tissue in the nose, sinus pressure when I physically touch the face, look in the back of the throat. Do I see enlarged tonsils? Do I see irregular appearing in the back of the throat called cobblestoning? Do I feel a mass in the neck? Or do I see something in the ears? Because sometimes things in the ears can trigger a cough. As well as, of course, the full exam of the chest. Do I hear wheezing, rhonchi, which are crackles or high-pitched sounds in the chest that may tell me where the cough is coming from? So just generally, when you look at it, the lung anatomy is extensive, and any one of these places, when they are irritated or even touched, can trigger a cough. So as I mentioned before, there are three major types of cough. Acute cough starts pretty much day zero, first day that you have the cough, and usually lasts up to 3 weeks. Subacute cough lasts about 3 weeks to 8 weeks. And then after 8 weeks, we start to call it a chronic cough. And it can be about 2 to 3 months, but it can last. And sometimes we see people who've had a cough for 1 to 2 years by the time they decide to seek help. First, we'll talk about acute cough. So most common cause of acute cough, and most people will take care of their own cough, a common cold or upper respiratory infection. Bacterial or viral is the most common source, and they're usually very self-limiting. We cough, we sneeze, we kind of feel under the weather, and then we start to get better. And symptoms associated can be postnasal drip, sore throat, nasal discharge, and congestion. And you can see here the primary location that's inflamed is the upper airway in the nose, and it can extend even to the back of the throat where we have that sore throat. In acute cough, acute bronchitis. And in our acute bronchitis, a lot of people have these very stringent definitions, but acute bronchitis, which is inflammation of the actual bronchial tree yet again, can be associated with or without mucus. It's usually associated with a soreness of the chest, signifying that it's the bronchi that are really inflamed and irritated. And it's usually associated with fatigue and tiredness. Not so much fever, not so much chills. And you can see here the location when we're looking at the bronchial tree. That's the part that's inflamed, and you can see where the secretion is. Allergic rhinitis, which almost everybody experiences sometime in their lives, usually associated with watery eyes, runny nose, or itchy throat. And it's, as I said, demonstrated, can be caused by pollen, dust mites, animal dander, or any even more specific kind of irritants in the air. Pneumonia can cause an acute cough, usually associated with fevers, chills. Pleuritic chest pain, which is chest pain that hurts when you take a deep breath. It gets worse when you take a deep breath, and it's relieved when you breathe out. So people tend to try to limit how deep they breathe. Also associated with fatigue, general malaise, which is just feeling kind of poor and tired. And you can see here a pneumonia. The pneumonia that I have is the white hazy patch, and it can be well surrounded by normal healthy tissue, and it can trigger cough, and usually can evolve into what we call the pleuritic chest pain or persistent chest pain when it extends to the periphery, when it extends to where the lungs end, because the lungs are surrounded by a nice sensitive lining of tissue called the pleura, and when that pleura is irritated by the inflammation and infection, it hurts. And so when people take a deep breath, they really feel it. Congestive heart failure, and this is sometimes associated with the history. Person has a history of a weaker heart, or they've had a recent history of a heart attack. Congestive heart failure can be the primary source of cough. Shortness of breath can be associated with it. Leg swelling, fluid retention, kidney dysfunction, orthopnea, where people are short of breath, and they can have that shortness of breath get worse when they lay down. COPD exacerbation, yet again, where the physical exam and the history mean a whole lot when we're evaluating the cause of cough. Tobacco history is common, but not necessarily necessary. Shortness of breath can be directly associated with it. Activity limitation, where people are unable to do the activities that they were able to do before the cough started. It can be associated with wheezing, but it's not required. And patients can experience an increase in sputum production, but sputum production is not necessary as well. You can see here the change in the airway. What's COPD, and this is the emphysematous part where you have normal lung tissue at the bottom, nice and pink, and you have each one of those little air sacs. And with COPD, you have destruction of those air sacs. Other things that may contribute to cough are asthma exacerbation, wheezing and shortness of breath can be associated, or pertussis. And people hear of pertussis all the time, and it's caused by Haemophilus influenza, a bacteria that can cause infection. Whooping cough in children, and for most people nowadays haven't seen it because we vaccinate our children and we vaccinate our adults. Children take a deep breath in and they have this high-pitched whooping sound when they're breathing in. More in adults, it can cause paradoxical cough, and that's that unrelenting cough. People will have it and they can vomit, they can break ribs, they can herniate a disc, and they would end up going to the doctor a little bit faster because it's such a severe cough that just doesn't give them peace. And so that's also important. There's really no picture or graph for that, though. Then we move on to subacute cough. Subacute cough, as mentioned before, lasts about 3 to 8 weeks. It can be a post-infectious cough. After a cold, you can have that and it slowly resolves by itself. Viruses and bacteria can leave things inflamed, and until that inflammation is calmed down, and we provide symptomatic relief, which we'll talk about later. Pertussis, yet again, if it's not treated in the first 2 weeks, it can lead to a persistent cough that can be quite irritating, since it responds well to the antibiotics in that first 2 weeks. weeks. Postnasal drip, as well as reflux can be associated with subacute cough. And then chronic cough, and that's what usually leads people to the doctor most of the time. That's defined by 2 to 3 months of existing cough, and it can be triggered by drugs, tuberculosis, Mycobacterium non-tuberculosis, interstitial lung diseases, lung cancers, aspiration, cardiac causes, as well as psychogenic habits and tics. I mentioned ACE inhibitors, most common, usually can start within a week of starting therapy, but can actually be delayed up to 6 months. So people can be on it for a few months and then develop the cough. There has been rare studies that have shown it can develop even 2 years after. It usually starts as a tickling or scratching or itchiness in the back of the throat. And when the medication is discontinued, not saying it should be discontinued because this is a conversation definitely with your physician before you do such a thing. It usually resolves in 1 to 4 days, but can take up to 4 weeks to resolve. It does occur more commonly in women than men, and it can occur more commonly in the Asian population than any other population. And these are just a few examples of ACE inhibitors, because sometimes people don't know exactly what we're talking about when we say ACE inhibitors. Different types of medication like enalapril, captopril, lisinopril. The 3 most common causes, and that's where I'm going to focus on, because most people who come to their primary care physician or to even a pulmonologist and complain about chronic cough are usually in these 3 categories. The first and foremost most common cough is postnasal drip, which is actually called upper respiratory syndrome now. The second is asthma, and the third is reflux or GERD. Postnasal drip, as you can see in this picture, I think captures the essence of postnasal drip as well as you possibly can. The upper airway and the nasal area is inflamed, it's irritated, be it from a cold, infection, or even allergy, and it's producing a tremendous amount of secretions, and those secretions drain the back of the throat. And as I mentioned, the cough is triggered by stimulus or irritation of that posterior airway tissue all the way down through the lungs. Well, that thick, inflamed secretions can drip down and easily incite a cough. Once the secretions are present in the back of that airway, as mentioned, we stimulate that cough receptor in the back of the throat. The sensation of liquid dripping back is usually described as that tickle, and it's associated with frequent clearing of the throat. On physical exam, one of the most common things that we're looking for when we look at the airway is we're looking for turbinate swelling, which I mentioned early on, but cobblestone appearance in the back of the airway is one of the key findings that we associate directly with postnasal drip. And this is what it looks like, and you can see the uvula in the middle, but when you look further back, you see heaped up tissue. And that heaped up tissue is actually normal tissue, and around it you see a paler pink with nice clear blood vessels, and that is actually tissue that's lost the top mucosal layering in the back of the throat. It doesn't hurt, but it feels kind of, you have an awareness of it, and it comes from that constant clearing of the throat where you shear off that layer of tissue. And this is what the doctor is looking for when we look at the back of your throat and you're complaining of constant sort of tickle and clearing of the throat. And this is a great sign. That's why I included it. As mentioned before, postnasal drip causes include allergic rhinitis, which means just allergy, itchy eyes, runny nose, and that secretion in the nose, congested nose, and that inflammatory secretion is dripping in the back of the throat. Perennial non-allergic rhinitis, which means things that we are having reaction to all year round that's causing irritation and inflammation of our airway. Of course, colds, acute nasal pharyngitis can cause it. Vasomotor rhinitis, which means you've been treated for a lot of different things and you have this increased blood flow and increased tone into that airway, and you're producing those secretions. And sometimes that just sort of requires symptomatic relief because there's no avoidance. Sinusitis, chronic or acute, can lead to postnasal drip as well. How do we treat? So there are a lot of different medications, but the one medication you don't see there is a nasal decongestant. Things, and I'm not going to mention any kind of brands, but people like to resort to nasal decongestants because they shrink the tissue and they open up the airway really quickly. They dry things up and people feel better temporarily, but those can actually do more damage than good. So I didn't include that as a traditional post-nasal drip treatment because that would really require a doctor's recommendation, sometimes an ear, nose, and throat specialist. These are the medications that primary care doctors and physicians, such as a pulmonologist, would use. Oral or nasal antihistamines. Oral decongestants at times, as long as it's safe, and those are medications that would require conversation with your primary doctor or the pulmonologist because those medications can definitely do harm in people who have kidney problems, history of high blood pressure, or blood pressure that's poorly controlled. There are medications like montelukast, which are oral leukotriene receptor antagonists that can also help. And because it's now called upper respiratory syndrome, a lot of the recommendations are using first-generation antihistamines. Those old histamines like Tavis that are out there that actually can dry out the tissue, stop the secretion production, and we can choose to use them with or without decongestants based on the patient's health and medical problems that may be worsened by using the wrong type of medication. And sometimes the postnasal drip may require antibiotics, especially if there's an acute sinusitis or a chronic sinusitis there that continues the secretion production. So next, the second most common cause of chronic cough is asthma and cough variant. And a lot of people have heard their doctor talk about cough variant, where it just really points out to smaller airways. When we wheeze, we tend to have inflammation of larger airway associated with asthma. But when it's really the smallest portion of our airway and we have no wheezing, cough can be the primary presenting factor. And so people can cough and it can be just as severe as a wheezing asthma attack. People may have shortness of breath, especially with exercise, and it may be triggered by behavior, exposures, triggers, or antigens, being around a pet or an animal or some kind of vegetation, some flowers, hay, things like that. You can see here, asthma, by definition, reversible, so we love that. People can have a nice open airway and no cough, and then they're exposed to the trigger and whatever causes the irritation, and then all of a sudden have trouble moving air and coughing and feeling terrible. Once they rest, they can return back to normal and that cough can calm down. And so it can definitely make people feel confused on whether they need to go to the doctor or not until they become frustrated or become more severe and start to have more symptoms. How do we treat cough variant asthma? And don't forget, this is before we even do any further workup. Sometimes we'll provide rescue inhalers, albuterol inhalers. Then we see 30 minutes before exercise or before they're exposed to something that they feel is a trigger or something that triggers their symptoms or makes them cough. And if that's successful, we may move on to what we call inhaled glucocorticoids, long-acting inhaled steroids that can calm down the inflammation and let the body heal. Sometimes when it's severe enough, a person has severe enough cough, maybe we'll use systemic corticosteroids in order to calm things down more aggressively. And some people will use something like leukotriene inhibitors, montelukast, which sometimes can actually block the allergy-triggered asthma that people have that can be associated with cough variant asthma. Third, we have reflux. And so reflux, gastroesophageal reflux is the third most common cause of chronic cough. And you can see here, I love this picture because it really shows what's going on. And what you can see here, oh, I don't have a little mouse. You can see where the diaphragm separates the esophagus, the purple part, from the stomach, and there is what we call a lower esophageal sphincter. And that closes off the stomach and prevents all the gastric acids and contents from going into the esophagus. Well, some people don't have a very strong lower esophageal sphincter tone, or they might have increased abdominal pressures that override that. And so you can see that all that liquid from the stomach, which is an acid and it has a low pH, so it can be quite irritating, going into the esophagus. And the esophagus is really not built for that exposure. And if you recall at the beginning of the presentation, we talked about the esophagus having cranial nerve number 10, which is the tone, the cranial nerve that picks up the symptoms and what we call the sensory of the esophagus. And it sends a message to the brain, and the brain says something's wrong, and it can actually trigger cough very commonly. So symptoms associated with reflux or GERD: sour or bitter taste in the mouth when it's occurring. It commonly can occur after meals or after very specific triggers. Certain types of food that are more common to trigger reflux than any other food. Caffeine is one of them. Acidic foods, sometimes chocolate. Some people can complain of discomfort after meals, but it doesn't have to be associated with discomfort after meals, especially if it's occurred for a longer time. And the treatment, there are a lot of treatments. For most people, when they're talking about esophageal reflux or GERD, they know H2 blockers, ranitidine or famotidine. They also, because of the commercials that are out there, proton pump inhibitors, Nexium, Prilosec, or Protonix. But the most important thing that we always try to teach people is lifestyle modification, because all those medications above we like to use for a temporary period of time until we resolve the problem. If we can resolve the problem with lifestyle modification, we can be considered even more successful. So weight reduction is one of them, especially because higher weights can actually increase our abdominal pressure and increase the occurrence of that reflux. Some people will raise the head of their bed, and we're not talking about having one of those beds that just lifts up the head, but actually the entire bed is at an angle. And that helps keep the reflux from occurring as significantly or as severe. Avoidance of the reflux-inducing foods or beverages. And it's very important because a lot of people have reflux just because they have that late night snack or a late night meal. Avoidance of meals 2 to 3 hours before lying down can help substantially decrease the symptoms and the occurrence of reflux for a lot of people. There are anti-reflux surgeries, Nissan's fundoplication, which is a fancy word, but it's a surgical procedure where they actually change the position of the stomach so that there's a stronger tone in the lower esophageal sphincter in respects to prevent that reflux from happening. And there are LINX procedures where they have a little cuff around the lower esophageal sphincter, and that can keep that acid from going into the esophagus. And so those are last resorts if the medications don't work, if the change in lifestyle is unacceptable or doesn't resolve the symptoms. The important part when I'm talking about this is that cough can be very much associated with reflux. And as I mentioned before, things that wake you up, and feeling unrested is a terrible feeling. And so when you go to sleep and you're coughing before you go to sleep, you finally fall asleep, we use that reflux, that cough that occurs and wakes you up in the middle of the night to figure out whether it's asthma or reflux or postnasal drip, because asthma doesn't tend to wake you up, but reflux and postnasal drip can make you choke and cough in the middle of the night and can lead you to have a much less restful sleep. Still, despite everything that we do and all the medications, sometimes people just don't get better. And there's a lot of reasons why people don't get better with the initial treatments that you will get from your primary doctor, pulmonologist, ear, nose, and throat specialist, or allergist. And sometimes it can be because you need more aggressive therapy associated with the one primary problem, or you could have multiple causes at the same time. It's not unreasonable for a person to have a postnasal drip as well as reflux. And once a cough is primed, a cough can be more persistent until you take care of all the causes. And that's when we go, after we've tried our initial treatment, based on the history and physical, we can start utilizing more advanced technology. So after a course of therapy for about 4 weeks, up to 6 weeks, sometimes we'll have to do a chest x-ray to look for more advanced problems. There's a whole bunch of different tests depending on the direction that we're going based on history and physical. So having a direct laryngoscopy evaluation by an otolaryngologist or ear, nose, and throat specialist may help. They'll look in the nose, they look in the sinuses, they see postnasal drip. They can also help to see if reflux is reaching to a point where it's causing spasm and irritation of the actual larynx. And that could be a severe form. So a lot of people think it's only for the postnasal drip and the upper airway, but ear, nose, and throat specialists can assist in evaluating really bad GERD or reflux. We use spirometry or pulmonary function tests to evaluate for asthma or inflammation of the lungs, as well as restriction of the lungs, because both of those can contribute to the presence of acute and chronic cough. CT scans of the sinuses, neck, or chest can look for abnormalities, as well as GI specialists can look for inflammation and damage of the esophagus. And you see other tools that I'll talk about. As mentioned here, I went off script, I apologize. The direct laryngoscope, laryngoscope evaluation can really show not just postnasal drip, it can look at the vocal cords and see if there's abnormalities of the vocal cords, tumors of the vocal cords. It can look and see if reflux is causing significant damage, because they would look and evaluate whether there's inflammation of the upper airway. And when there's no inflammation of the upper airway, but we see that reflux-induced, that acid-induced injury of the pharynx, it can help the GI doctor or the primary doctor change the medication or be more aggressive. It can be associated with hoarseness, change in voice in other ways, weakness of voice, as well as the chronic cough. As mentioned before, advanced imaging. We love advanced imaging, but we try not to do it unless it's necessary. Evaluating the sinuses with a CT scan of the sinuses can look for chronic infection, chronic sinusitis, bronchiectasis, which yet again is scarring of the actual bronchi and can be associated with chronic infections that are subclinical, so they can last a long time, not necessarily going to trigger cough or fever, but can trigger cough, they're not likely to trigger fever or chills, but can really push cough for a long time. It occurs from severe and repeat or persistent airway inflammation, and once it's there, it really doesn't go away, and so it can lead towards progressive airway damage. Cancers of the neck, head, or chest can be diagnosed and aggressive therapy can be initiated, as well as different types of interstitial lung disease. And that's an inflammatory process and a scarring of the lungs, which can lead to a much harder to control cough. GI-wise for reflux, we have the EGD as mentioned before, which is something that the gastroesophageal specialist will do, looking down, taking biopsies, and determining whether or not the acid contents of the stomach is causing damage to the esophagus, or the presence of even a hiatal hernia, so that patients will have a more reflux where they're requiring a surgical intervention. There's also esophageal dysmotility. Sometimes people have spasms, and that can contribute to cough, and that can be diagnosed with barium swallows as well. So it's important after you evaluate that, the cough, and we do all this evaluation, it's still important to realize that there are complications associated with cough. And so, yes, we have to identify the cough and we want to treat the cough, but sometimes we have to suppress the cough as well. And that is because the cough can generate really high interthoracic pressures. 300 millimeters of mercury can be reached. And as mentioned before, the expiratory velocity or speed that you can cough out can go up to 500 miles per hour. That can lead to intense exhaustion. It can just wipe people out. People nowadays, more than any other days, welcome to COVID-19, the self-conscious nature that we have when we cough in a restaurant, or when we're at a class, or if we have someone in school, or even at our workplace. There are a lot of eyes that turn to us right away, and so people are highly self-conscious over cough now. Insomnia, if you can't sleep because you're coughing, or headache. People who have chronic headaches and they have a cough can make it worse, or it can be severe enough that they can generate a headache. Dizziness, musculoskeletal pain because of continuous cough, hoarseness of voice, or urinary incontinence can lead to very bad situations. The most severe complication, which can be associated with pertussis, is cough-induced rib fractures, and that can happen. People who have weaker skeletal frame, people with osteoporosis, are at even more risk, but fractures can happen in young and healthy people because they have the strong muscles as well. And they're primarily associated with rib fractures from number 5 through 7, and that's a concern as well. So if we have a cough that's definitely not getting better while we're evaluating it, we still need to treat it. And there are some coughs, even once you diagnose the cough, just are irreversible and you can't get rid of it. So you have to know how to treat that as well. The first thing that we use, depending on the severity, are non-narcotic cough agents. Dextromethorphan is a centrally acting cough medication. It works in the brain and it's synthetic. It can improve cough for some people substantially, but some people it's not as effective. So we always advise when people try dextromethorphan, definitely follow the recommendations because higher doses can cause nausea, dizzying, vomiting, and headache. It should be avoided in people who use monoamine oxidase inhibitors because it can make you very sick. And it should be avoided in people with liver problems. The dextromethorphan is central acting, peripherally acting, or really at the site. When we're talking about a cough medication is Tessalon pearls. Tessalon pearls are these tiny little pearls, and they numb up the vagus nerve as we swallow them and they go down the esophagus. They numb up that cranial nerve 10, that vagal tone that is hardwired into our cough center. And so that can calm down the cough by, on average, about 20 to 30%, making it bearable, as well as it's a non-narcotic, so people can use it when they're working or when they're active during the day. Now, when the non-narcotic cough suppressants are not successful and life is still intolerable because of the cough, there are narcotic antitussive agents. These are centrally acting: codeine, morphine, hydrocodone, and some people remember them. They're more Robitussin AC, Tussinex, Cheritus are more of the brands that people recall. These medications are quite good, but they can leave you feeling drowsy, which makes them very hard to use during a work day or a business day, or when you have to drive or work equipment, because the recommendation is always to not get behind the wheel when you're using these, to not work with machinery or even cook, because you can cause harm to yourself and others. When they're used too high of a, at higher doses, they can definitely have an increased side effect profile. Addictive nature also is a concern. Increased risk of falls, lightheadedness, dizziness, as well as constipation are very common side effects of cough suppressants. So we try to balance that, with taking care of the cough at night, and during the day we usually try to stick with the non-narcotic cough suppressants. Then there's chronic cough alternatives that are more used for people with specific problems. So gabapentin and pregabalin are two medications that a lot of people are familiar with for neuropathic pain, diabetic neuropathy, which, when people have that pain in the legs, the foot, they have chronic back pain, damage to their spine. Those are really good medicines we use that calm down that pain, and it calms down the nerves that are sending signals causing that pain. Well, they actually have found that gabapentin can be used because the C fibers in our lungs that really send that trigger, and then in our airway that send the trigger and stimulate that cough, can sort of follow the same kind of pathway. And instead of having pain, we have cough. And so gabapentin and pregabalin have been shown to help for cough that's irreversible or that's persistent. And you see thalidomide. Thalidomide is still a medication that's used. It's used a lot more carefully than in the past because of the side effects. But thalidomide has been shown to help people who have interstitial lung disease, pulmonary fibrosis, where they have that unrelenting cough. And the mechanism is not clearly documented yet, but it has helped people improve cough. And in rare cases, we use aerosolized lidocaine. The danger of using aerosolized lidocaine is that it definitely decreases the ability to feel in the back of your throat and so you can increase your risk of aspiration. However, for some people that is necessary. Okay, and the most important part about our cough is it's about airway clearance, airway clearance, airway clearance, airway clearance, and I think that it gets my point across. Cough is a symptom, and it is there to protect your airway. Sometimes that protection can go astray and become more of a negative consequence than a helpful consequence, but for the most part, our cough is there to keep our lungs clean, clear, and to help us function and stay healthy. I do think we have some questions. Okay, so the first one I have is, which type of cough is more concerning, a dry cough or a productive cough? So I don't know if you saw that, it was only one slide, but it definitely said, you know, sputum doesn't really help us distinguish between a concerning cough or a non-concerning cough. If you're producing a lot of secretions, sometimes that would suggest that you have an acute cold or some kind of inflammatory process. But I think it's more the length and the time that you have with the cough. If that cough is there and you've done everything and it's been 8 weeks and that cough has not let up, that becomes a concern where it just shouldn't be ignored. It should be evaluated, whether you're producing secretions or not. And so it can easily be misleading. One person who can produce a tremendous amount of secretions can have the same problem as somebody else who's producing no secretions. And secretions can be swallowed. Most of the time, we produce a tremendous amount of secretions naturally, and our airway handles it. We actually cough up secretions all the time, and we swallow them, and our body sort of clears them naturally. So don't be misled by the lack or the amount of secretions. There are some disorders that are defined by secretions though, so chronic bronchitis by definition produces a large amount of secretions. That would also go along with a history, a diagnosis. Okay, I've been doing this and every year I have 2 months or a long period of time of producing 4 or 5 tablespoons or half a cup of secretions, and then the doctor treats me and I get better. That can be less concerning, but I would not establish that very early on, especially if it's a newer cough or it's only been there for a few months and you have no general history of that. I think I answered that. And then the other one is it true that pineapple juice can help reduce a cough? If yes, why? Well, I have no research that pineapple juice can decrease a cough. Sometimes people can have secretions and they will drink something that's more acidic to help that secretions clear. And it's more really the same technique as people who have a lot of postnasal drip or a cold, acute infection of the nose, and they use nasal saline. We apply that nasal saline or the rinses that people use because it thins up the secretion, and when they thin up the secretion, they wash it away. They get rid of that that irritation in the back of their throat, so it can calm them down. But it's temporary because once the nasal tissue or the back of the airway produces that secretions again, or what happens is it starts to irritate, we start to feel that tickle, we start to cough again to clear the secretions. And every single time we clear it, the body is going to replace it. If we don't take care of the underlying cause, your body is going to produce more secretions and cover that airway. And in the sputum, if you're producing sputum, you're going to have inflammatory cells, and those inflammatory cells can be really irritating. With that irritation, you're going to cough again. So that's most likely the probable cause. Oh, I have another one. So it says, when I produce secretions with my cough, does it matter if I swallow or spit out my sputum? It doesn't matter. Most of us swallow our sputums most commonly. When we're feeling healthy, we still produce a significant amount of secretions because we always have that cleaning process, and that's what the secretions are. When we have a lot, if it's really hard to cough it up and it's easier just to swallow it, then it's fine and natural to swallow it. Usually when people have a lot of secretions, they have that really like a waterfall postnasal drip, that's when they start coughing it up, because when they start swallowing too much of it, it may cause an upset stomach, or it may make them, have emesis afterwards, because it's really hard for the stomach to tolerate large volumes. And so it's really a preference, whatever's more comfortable. Sometimes we're not in a situation where we can cough it up without causing too much attention or feeling like we're just doing the wrong thing, and so swallowing doesn't hurt. At home, if you have a chance to examine it, some people would like to be able to describe it to their doctor. Going from my sputum was clear last week to my sputum is dark green today. Or what I always look for, I said, for the most part, people don't really discern clear from any other color, because dehydration and medication can affect the color of your sputum. If you're using a decongestant, you can change the color just like that. But if there's blood in there, you want to always be able to say, oh, well, my sputum was clear or yellow and now it's blood, and red tends to be a color that tells us call doctors immediately. So anything red, I would always involve people, a physician in, even if you're having a nosebleed. But I think that answered that question. All right, so I do thank you for listening to my first ever YouTube presentation. And thank you very much. I hope I was able to help some people.